So our first speaker is Scott Elster. He is the Chief Executive Officer of Prolacta Bioscience. He has extensive experience in the biosciences and in the financial sectors with expertise in planning, finance, strategy development, and supply chain operations. He spent 13 years working at Baxter, where he focused on plasma products worldwide. And we've had some discussion about human milk and the similarity to blood products in biological ways. He received his BS from California State University and his MBA from the University of California at Los Angeles, and we're very pleased that he's come across the country to be here at this event.
Thank you very much, Cindy. I appreciate that. I'm really honored to be invited back because I think this conversation benefits the entire industry. I have to start off and tell you, as a snooze warning, I'm glad it's 9 in the morning, that I'm going to really be talking about regulations and quality, so maybe not the most exciting talk. But I want to start with my disclosures. That's my way of saying that I get a paycheck every 2 weeks from Baxter, or not Baxter anymore, Prolacta Bioscience. I actually had preemie twins, 33-weekers that used Prolacta's products, and I do appear shorter in person. So I'm going to cover just a little bit of the ground that I talked about in Cleveland, and I'm going to start with World War II, and the reason this is important is December 8th was the first time a plasma derivative was used. Now, to me, milk is white plasma. It's incredible. The similarities are incredible, and every time I make that analogy on anything, I don't really miss. And I'll show you what I mean if this will work. In the beginning, albumin, as I just shown you, stabilizing troops in World War II. Then the IGIVs, the immunoglobulins, they started breaking it down into other products. They went to the coagulation factors and made meaningful differences in lots of people's lives, and still doing that today. Anticoagulation factors, and then other, as they continue to explore. And I always think about plasma as the Sahara Desert and milk as the rainforest in its biodiversity. Milk is incredible and very understudied. Recombinant proteins then, of course, came out of this. Let's start about milk. Same thing, Habana, a standardized donor model of milk. Prolacta came around, made some different formulations, broke the milk down, put it back together, created the Prolact 20 and 22, Neo 20, Prolact HM. Then we got a little more sophisticated and created the human milk fortifiers, the concentrates that provide extremely preterm infant exclusive human nutrition. We've recently introduced a line of ready-to-feeds, which are called human milk-based preterm formula, something creative like that. The FDA helped us. Other derivatives coming, Prolact CR. It's a caloric boost. And I remember when we studied this, everyone just laughed and said, this doesn't matter, energy doesn't matter. Sure enough, linear growth was better, weight gain was better. And there might be some implications on bronchiopulmonary dysplasia. That's the subject of the second study of this product, which begins any day now. I think we have a baby enrolled. We're doing 240 babies, and we're looking at adding cream to everybody. And so maybe the protein to energy ratios are a little messed up, and this might actually help growth. We're going to see. We're going to study it the way we do. Human milk fractions are coming. Sorry, I digress. Prolact HMOs. We aren't that creative. These are HMOs that are in milk. We have a process now that concentrates and purifies them. We're going to be putting those into animal models. If you listen to them at Cincinnati Children's, they think this might have an impact in graft versus host disease as we start to move out. But we're going to first look at the impacts of necrotizing enterocolitis and inflammatory bowel diseases. Again, science of human milk. Study it. Other fractions that are interesting and a long way off, secretory IgA could be a really interesting standalone product. There's stem cells. What do they do? What could they do if they were collected? And then there's cytokines, growth factors, and numerous items that we don't even understand yet. And ultimately, I think recombinant proteins. I'm going to take you back and talk about COT. This is a committee of 10,000. Corey Durbin, who I'm sure no one in this room's heard of, contracted HIV in the late 80s, from plasma derivatives, hemophilia products. He was one of 10,000 people, committee of 10,000, that contracted HIV. And he was calling for better standards and better safety. Now, HIV was a shocker. No one knew what it was. They didn't identify the disease and the cause until '86, but it impacted lots of people in the blood supply, lots of people there. I can kind of forgive that one, right? This is brand new. It's never been seen before. 93, plasma derivatives, biologics, GammaGuard, infected about 230 or 240 people with hepatitis C. Now, we knew viruses were there. We put all the measures in place. The best thinkers in the world had decided that the plasma industry would be safer if we adopted a new, better hepatitis C antibody test. Well, what happened was it was very successful in removing all the antibodies. Unfortunately, virus is there without antibodies sometimes, and this led to a problem. Now, the good news in this slide, and there's very little good news about giving someone hepatitis C, is how fast it was recognized and shut down. And that was because of what happened with HIV. The vigilance got better. The systems improved. So we ask ourselves at Prolacta, is donor milk, are milk products safe enough? And that's a fundamental question of our company every single day. And the answer we conclude is no. Not because we're not doing everything we can do or think to do, but because safety and quality is a journey. It is not a destination. You need to continually improve. We say those that can't remember the past are condemned to repeat it. And we view the analogy of plasma as the analogy of milk. And we need to get ahead of it. So what do we do in remembering COT? We DNA match. We DNA match every mom so that we know every single drop of milk that goes into our system is tested. It's essential. We test for drugs. We test for dilution. We test for adulteration. We've validated these tests. We've used state-of-the-art testing companies to help us develop tests that work for milk. We then test our product once we've received it for HIV-1, HPV, and HCV. And I remember one time I got asked, well, Scott, don't you trust your process? And the answer to that is no. I don't trust anything. I have redundancies everywhere to make sure this can't get through. Now, I am shaped by the Committee of 10,000. I am shaped by a World Hemophilia Federation meeting where industry people didn't go because there were threats they were going to stab people with blood-filled syringes. So I may be a little on the extreme, but that's okay. We like Don Rumsfeld, known and unknown, and the unknown unknowns. And when we think about the plasma model of safety, that's really apparent. We have known risks. We know about viruses, we know about bacteria, protozoa, prions. We know these things, and we do things to address all of these risks. It's the unknown that keeps me awake. What new thing is coming? How do you look at this? How do you figure it out? And how do you know how to act? And that's a daily question. We manage risk in a very layered way. We start with donor screening, and we screen those donors, and then we ask their physicians if they're healthy. We have specific questions of the pediatricians, are they breastfeeding, and we get all that data in. Then we test what they say, and we test the donor themselves, of course, and we also test the donations, and we test the donations for a myriad of things. Right when they come in as part of the qualification process, because it's our goal that the processes for the milk are so good that the other processes are unnecessary. That's the goal. Eliminate as much of the contamination, as much of the problems as you possibly can. And then you need to have validated processes. You need to understand what your process and equipment can do. You have to study that in a scientific way. You have to understand the pathogen reduction so you know what limits to set. And then you have to have quality systems, that document everything that happens. Because if it's not documented, it did not happen. If it's not verified, it did not happen. That's the issue. The last piece is the medical vigilance. I had never heard of chikungunya virus. And when I heard about it, it finally got to the press. Yes, okay, good. There's two of us. I hope I said it right. So I said, well, what are we doing about this? Oh my God, it's in the press. And 5 months before that, we had put a travel restriction to the Caribbean. If you had traveled to the Caribbean within 60 days, you couldn't donate. And that's because our medical director is an infectious disease doc. He's constantly looking at that. We view plasma as the canary in the mine. What's AABB saying? What are their concerns? How do we address those concerns? What are the model viruses for things that are emerging? It's really important, and it's hard work, and it's every single day, and it constantly changes. We were updating our drug tests because we didn't think they were good enough. We wanted to validate them and make them a little bit better. And we were talking with the lab we were working with, and they said, why don't you test for smoking? And we said, well, the moms tell us they don't smoke. It says right here, I can show you, no smoking. They said, really, that's interesting. Well, there's a study that just came out that said 1 in 5 breastfeeding mothers returns to smoking by 8 weeks postpartum. That doesn't mean if they didn't smoke, they start smoking. But if they were smokers and they stopped, then they start again. And 2 in 5 relapse by 26 weeks. And we said, oh, okay, I guess that makes sense. So we put a test in. And we found a lot of people return to smoking. And we put a process in, and the level and the limit of detection we use is the same thing as an insurance company. So if your insurance company says you're a smoker, we would say you're a smoker. And I don't know what the dose of cotinine is for 25-weeker, but I think it's 0. And so we've thrown away 15,000 ounces of milk. That's not true. We don't throw it away. We use it for research. We don't throw that stuff away. It's too valuable. But we do not use it. We discard it, and we disinvite these people from donating in the future. Important stuff. It's moving the bar. We believe asking the donor is really good, but it's not good enough. We need to be able to trust but verify as many things as we possibly can. DNA matching. We get this question all the time. I just answer it now. Who would possibly donate other milk? It doesn't make any sense. And then people say, well, okay, maybe if you're paying for milk, then that might be an incentive to do it. We say, okay, that's fair. And we have had that happen one time. We had a mom who was donating, and we disinvited her from donating. And 6 weeks later, we had a different address, a different name, a different doctor, a different baby birth date. Weird though, same DNA. And no one could figure out how that happened. We called and talked to them, and they just couldn't understand it. So, I guess it could be a 1 in 10 quintillion shot that happened, but we don't think so, and we never really heard from her again. So we think it's really important, particularly in a paid model. But actually, we've seen a lot more DNA mismatches that are unintentional. And they look like this. My freezer went down. Oh my God, what can you do with my milk? Oh yeah, bring it over, put it in my freezer. Great. I take it all out. Maybe I don't take it all out. Maybe I never need it again. Mom, helpful neighbor, mom donates, is all excited, sends it in. DNA mismatch. Huh. The other thing that happens in this one, I'll tell you, doctors, they all look at their feet when they see this one. That is a fridge in a NICU. And we have a 26-weeker, and that baby's been there, I don't know, 14 weeks. And they love the family. They love the nurses. They're hugging each other. Baby's going home. We're all excited. Nurse goes, grabs all the milk, hands it to mom. Mom's excited. Everyone's happy. They go home. I took preemie twins home, by the way. That thrill is quickly, when you don't have to sleep for about 4 weeks, it's quickly evaporated. They go home. Mom is a great producer, never needs the milk, ships it in. Huh. DNA mismatch. Now, can our systems handle some issues? Are we tested well enough to handle some issues? Yeah, we probably are. But you don't challenge your quality system, so we discard this milk. Use it for research. It doesn't go to babies. It's important. Good intentions, they're just not good enough. They're not good enough for the babies we're serving. I love this picture. This is hope. This is the dawn of time. And, you know, I can remember a day when I was at the Baylor Nutrition Conference, 2007. Steve Abrams stands up firmly at the podium and he says, 250 dietitians in the crowd, how many of you use donor milk in your institution? And about 5 hands go up and their heads drop in shame. Fast forward, 2013, he asks the same question. Every hand goes up. We know everybody doesn't use donor milk. It's 60% of the people out there using donor milk. But the shame meter has changed. You were shamed in the past for not using donor milk. For using donor milk. Now you're shamed for not using it. We've made tremendous progress, but it's just the beginning. There are more and more companies coming into this space. There are very low regulatory hurdles, and there are reasonable margins to be made. And it's time for us to try to take a stand and do something as an industry to make sure that this is safe. Because if someone else, not us, not Humana, not Prolacta, makes a mistake, the whole movement suffers. So in the long term, I really think we need to advocate for regulation in this space. I think we need to look for best practices. And as I was talking to congressional staffers yesterday, I sort of modified what I was thinking. You know, at first, being sort of ambitious, I'm like, yeah, we need regulation, we need biologics, and all that. They're not going to do that. But I thought, you know, maybe if processes of milk banks were audited by a part of the FDA, and we started on the continual improvement path as an industry, that might be really helpful. In the short term, I think we should be talking to each other and deciding what we want to do and what the minimum criteria is going to be. And I think we could start with a deferred donor database. So what is this? This is a situation where one donor milk bank doesn't accept a person for whatever reason that makes them not a suitable donor. Everybody knows privately, but everyone participates, and that person can't donate someplace else. It's what they do in blood. It's what they do in plasma. I think we should do it in milk. It sends a powerful message to the agency and to the regulators if we start self-regulating. The other thing I think is really important as a baby step is standardized labels. If we're going to deliver product that's going to be used in 25, 26, 27-week-old infants, there's things that the dietitians need to know to meet that child's nutritional requirements. And I think we should come together, figure out what that label is, and as an industry, present that to the FDA and start doing that. Those are just the minimum things. But the fact that we're in this room together, profit and nonprofit, is a great step. So, thanks.